presentation, also from Finland. I want to introduce to you now Professor Dr. Reijo Laaksonen from the University of Tampere, high throughput screening of new lipid markers for coronary artery disease. Please, Professor.
Okay. Thank you. I need to apologize first because there's nothing nano in my talk, not even a particle, but I tried to make my best to squeeze in those magic words in my presentation at some point. And the title is sort of complex, but my aim is to introduce the ceramide lipids as cardiovascular biomarkers to you. Nothing much more, but I think that's enough for 9 minutes. I will start with a very simple clinical sort of setting. I have here 2 patients with coronary artery disease. They're obviously Finnish people because they're so happy. I learned yesterday that Finns are reserved, quiet, silent. They want to go away, they want to talk. But it was published just quite recently that Finland is the most happiest country in the world. So this must obviously be Finnish because they're smiling, having a disease. But in clinical setting, if you want to screen for the risk and you want to tailor somehow the treatment and maybe in the future use these nano things to treat the patients with the higher risk, today it's not really feasible. There's stratification by risk. Because, I mean, there are some risk calculators. They're probably not so good, and they're complicated to use. Physicians are not going to the computers and not feeding, the data in. So what they do today is that, they check the LDL values, because LDL has targets for treatments, and there's statins and so on. So the general idea is that the higher the LDL, the higher the risk. So if there's a high LDL cholesterol, so this must be a high-risk patient. And we questioned that. Is that the case? It would be simple if that would be the case. But if that would not be the case, then it would be a bit more complicated. So we studied some 15,000 secondary prevention patients from different cohorts with established coronary artery disease and with a long-term follow-up. And our phenotype was cardiovascular death. So we compared patients with established coronary artery disease, and we compared those patients who died because of cardiovascular reasons to those who survived. And then we checked the baseline LDL. And the basic hypothesis would have been that those who died had higher values of LDL. But what turned out? It turned out that in all cohorts, the blue is with the event and the red is without event. The baseline LDL values were practically the same. No difference. In some of the studies, even the lower values were related to the higher risk. So in some settings, the association is reverse, not direct. But since, for example, statins or PCSK9 inhibitors are affecting the risk, we thought that there might be something, though, in the lipids, even if it's not cholesterol per se, it might be something else. And to this end, we started to do high-throughput screening using the mass spec-driven lipidomics technology. And we have done this in different cohorts, but this is just like our initial cohort, like almost 10 years ago, when we had a large-scale European project to study the biomarkers. And in this study, we compared patients with coronary disease with 3-year follow-up, and then those, again, who died and who didn't die. So survivors, non-survivors, vulnerable patients versus non-vulnerable patients. And we did the 650 lipid screening, and then we compared the lipid species between these groups. And in short, what we noticed, what we noticed was that the red lipids here, each ring is one lipid. So we noticed that the red ones which are the bad lipids, so they were directly related to the outcome. They were all different sphingolipids, for example, ceramides. And then the good guys, if you will, were cholesterol esters and phosphatidylcholine. However, with one exception, there was one ceramide on this side. And then I thought that, okay, let's do very unscientific statistical approach. Let's calculate in a shotgun manner lipid-lipid ratios. Maybe the lipid-lipid ratio would be important because it probably tells something about the properties of, for example, LDL particle. And what happened, it happened that we actually found some ceramide ratios that were highly significantly different between the patient groups, high-risk patients versus low-risk patients. And then we thought that this might be the way to go. Lipid-lipid ratios, use ceramides. And we have repeated this now in many other studies and published quite many papers. And therefore, some scientists in the field have actually suggested that ceramides could be the new cholesterol. I'm not saying that. Ceramides will not be the new cholesterol because they're more. They're not just innocent bystanders that are accumulating in a vessel wall. They are bioactive ingredients that promote LDL aggregation, upregulate cytokines, and also activate the platelet activity. So they have many biological functions related to plaque vulnerability and the risk of coronary disease. And these here are the main subjects, main ceramides related to the risk. This one is the protective fellow, and based on the data on about 70,000 patients, we have now generated a mass spec method, targeted method for the biomarker assay, and with that method we have now screened number of cohorts, and here just for comparability, you have the hazard ratios for the Ceramide score versus LDL cholesterol, HDL, high-sensitivity CRP, LP(a). And here you have the average hazard ratios, and you can clearly see that the hazard ratio for ceramides is a lot higher and more significant than for the other biomarkers, lipid biomarkers measured in these cohorts. And the other way of looking at this is to plot the Ceramide score value here, which goes from 0 to 12, and the LDL cholesterol, and see how it behaves against the risk of cardiovascular death. I think this is one way of visualizing the power of the new markers. Here we have the LDL values from 1.5 to 50 micrograms mix per deciliter to 200, and you see that the line is quite flat, so there's no clear association between the risk and LDL. But if you look at the ceramide curve here, after the score of 6, it seems that there's sort of an exponential increase of the risk. And now I will put the nano here, because I think this group of patients would be the target for nano-imaging or nano-treatment. And that actually, that's about 15% of the whole population with coronary disease. And I think that's a very reasonable number. If it would be 80%, then there would be no capacity to do all the tricks. Or if it would be just 1 or 2%, then that would be too little. But 10, 15%, a good number. And today, the most important thing with the Ceramide score is that you increase the compliance of the patients and you use really the existing treatments. However, the ceramides may also somehow provide new attractive targets for future treatment. And as of today, the ceramide test is already in clinical use in the USA by the Mayo Clinic. They licensed the test from us 2 years ago, and they're running it in Rochester, not in Florida. And it's also in market in Finland in all private clinics and in some public clinics. And now next we try to take over Germany, Belgium, and UK. And as usual, this was not really done by me, but by all the many collaborators we are having, and I just had the privilege to present the data to you. Thank you.
Thank you very much, Professor Laaksonen, for this very interesting talk with this new facet. Questions, please.
Thank you. Just a technical question for the assay. Is it by mass spectrometry alone, or do you have to analyze many type of lipids? And so how complex is the assay?
Assay is relatively easy. It's a mass spec based, but now we have all the standards for all the lipids, and it takes like less than 5 minutes to run, and you can do it with any mass spec you have in a lab.
Please.
Do you know where in your sample this ceramide species originate from? I guess they are not in lipoproteins, but somewhere in cells, or do you have an idea about that?
Well, in a way they behave like cholesterol. The main source is liver, but they also coming from diet, and they are loaded into lipoprotein particles. Half of them are roughly in LDL, and then the other half between HDL and VLDL. But of course, they're synthesized also in macrophages and probably also in vessel wall and other tissues.
Okay, thank you very much. I think this is a very interesting topic. There are many questions for the coffee break. I want to announce